I thank Jodhir sir for once again inviting me to chair this last session on driving ahead diabetes. And actually, as you know, Kerala is the land of travel and tourism. It's God's own country. We are all belonging to a society where all are in love with traveling and driving and all. We have a lot of foreigners visiting us, and we ourselves are also good avid travelers. So being a diabetic traveling sometimes can pose a lot of problems, especially like hypoglycemias. Neuropathy can jeopardize your upper limb as well as lower limb, leading to incoordination. Then there is a risk of autonomic neuropathy and hypoglycemia unawareness. You can get an MI or a stroke. I'm not putting fear in your mind, but these are practical difficulties and problems that are likely to crop up during either long-term or short-term travel, either as a driver or a passenger. So to dwell upon these and all, I have immense pleasure inviting a true international faculty, A.V. Raveendran sir, who used to be along with me in the medical education service, and he is currently working in Oman, to talk on this very socially relevant topic. Over to you, sir.
Thank you, sir, for the nice words of introduction. First of all, I would like to thank Jyoti sir and the organizing team for giving me an opportunity to present this. Coming to the topic proper, driving ahead, managing diabetes for safe and confident travel. I will be discussing under the following headings. So, as we all know, driving has become an important part of modern life, and the prevalence of diabetes is increasing worldwide, and a significant proportion of people with diabetes may be engaged in driving. Coming to the driving, it's a complex skill. Driving is a cognitively complex task because it involves various functions like executive functioning, information processing, visual processing, memory, and during driving, the cognitive system should rapidly adapt to meet the varying environmental changes. Driving is an example of visually guided behavior. It comes under light physical activity, but it is associated with considerable amount of metabolic demand as there is increased cerebral glucose utilization. So this is the driving complex cognitive task model where you can see vehicle and road environment, sensory input and cognitive function and motor output all are important for proper driving skill. And the vehicle and road environment include all the factors which influence like road system, natural environment, legal requirement, vehicle and equipment characteristics, etc. And visual and auditory pathways are the major sensory input, and various cognitive functions like attention, concentration, comprehension, memory, insight, judgment. All these are involved in proper driving skills, and motor functions like muscle power and coordination are also important. As we all know, diabetes is a common metabolic disease characterized by hyperglycemia and is associated with both acute and chronic complications. Diabetes affects the various organ systems in the body, and it interferes with the driving skills in many ways like fluctuation in blood sugar values, complications of diabetes like nephropathy, retinopathy and neuropathy, and associated comorbidities like hypertension, obesity, sleep apnea. All these can influence driving skill. And diabetes increased the risk of motor vehicle accident, and the meta-analysis found that it increased the risk of motor vehicle accident by 12 to 19%, and history of hypoglycemia, strict glycemic control, insulin treatment, past history of motor vehicle accident, all these increase the future risk of motor vehicle accident. And the history of severe hyperglycemia within the last 2 years increased the risk of road traffic accident by 4 times. And poor self-management skill is also associated with increased risk. We will see what are the various factors influencing, adversely influencing the driving skills. So these are the major factors like hypoglycemia, hyperglycemia. We will see all these factors individually. Again, the same driving complex cognitive task model, you can see that all the aspects of driving like sensory, cognitive function and motor function can be influenced by diabetes and its related complications. Coming to hypoglycemia, hypoglycemia is common in people who are taking insulin or sulfonylurea, and hypoglycemia impairs the cognitive function. It significantly delays the reaction time, impairment of attention and hand-eye coordination. So people with hypoglycemia unawareness and those who are having severe hypoglycemia which require second person assistance or medical care are at increased risk of motor vehicle accident during driving. So those who are having hypoglycemia unawareness should withhold driving till it is reversed. Acute hypoglycemia causes cognitive dysfunction at the blood sugar level of less than 3, that is 54, and it takes around 40 to 90 minutes to return to normal cognitive function even after restoring normoglycemia. So they should not start driving immediately after correcting hypoglycemia. And people with diabetes should not drive if the blood sugar value is less than 5 or 90 milligram. And those who are engaged in long distance driving, they should check the blood sugar every 2 hours. And if it is found low, they have to take rapidly acting carbohydrate, recheck after 15 minutes, and once it is stable or normoglycemia is achieved, they have to wait for 45 minutes. So in all patients with history of diabetes, a proper history regarding the episodes of hypoglycemia, its severity, precipitating cause, all these are important while assessing the fitness for driving. So we can see that hypoglycemia affect all the components like sensory input, cognitive function and motor function, thereby impairing the driving skills. Severe hyperglycemia can also cause due to various factors related to driving, like skipping of medication or change in diet habits or stress. And rarely, significant hyperglycemia can also impair the driving skills by impairing the cognitive function, motor and perceptual thinking. It also impair the judgment and decision making. Severe hyperglycemia can also cause seizure and electrolyte imbalance, which can also impair the driving skills. Diabetes-related visual problems. Proper vision is an important component for driving. Diabetes can affect the vision in various ways like increased risk of cataract, retinopathy, maculopathy, retinal hemorrhage, retinal detachment. In addition to that, rapid fluctuation in blood sugar can cause visual problems. So, a visual acuity of minimum of 6/12 in the better eye is required for drivers of private vehicles, whereas in most of the countries it is recommended to have a visual acuity of more than 6/9 for commercial vehicle drivers. Coming to diabetic neuropathy, diabetic peripheral neuropathy is the most common type of neuropathy. In those with diabetic peripheral neuropathy, there is decreased sensation, proprioception, and muscle power. So people with diabetic peripheral neuropathy take longer brake response time, and people with peripheral neuropathy find it difficult to gauge the pressure on the accelerator, brake, or pedals. So they use the middle range of the pedal less frequently and switch between extremely high and low positions of the pedal for more frequently. Whereas healthy controls show greater use of accelerator pedal over the mid-range. It shows that people with DPN have reduced fine motor control and proprioceptive function in the lower limb. The degree of coordination between eye and steering wheel movement is also important in driving. In people with diabetic peripheral neuropathy, also have reduced correlation between eye and steering movement. For people with diabetic peripheral neuropathy, it's found that the performance increases with practice, and various medication used to treat diabetic peripheral neuropathy, which can cause sedation, can also impair driving skills. Diabetes is also associated with various atherosclerotic vascular disease, like major complications like macrovascular complications like coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Those with coronary artery disease and cardiac arrhythmia need periodical medical assessment, and they can resume driving after stabilizing the cardiac condition. And in those with heart failure, if there is satisfactory response to treatment, minimal or no symptoms relevant to driving, and an ejection fraction of more than 40, they can resume driving. Diabetes-related cerebrovascular disease. An intact neuromuscular system is required for smooth driving. People with cerebrovascular disease have limb weakness and cognitive dysfunction, both of which can impair with driving skills. Dementia can impair driving skills as there is significant impairment of cognitive function, memory, psychomotor abilities, attention, visuospatial function, insight and executive function. But people with mild cognitive decline may drive safely and impairment depends upon the severity of dementia. So in people with cerebrovascular disease, the functional neurological deficit like limb weakness can interfere with driving, and they are at risk of recurrent stroke or transient ischemic attack during driving. And in people with recent history of TIA, the risk of recurrent TIA or stroke is highest in the initial weeks. So it is better to avoid driving for 2 to 4 weeks. Diabetic foot problems like diabetic foot ulcers, amputation, etc. can interfere with foot pedal manipulation affecting driving skills, but modified vehicle with handheld control systems are available to overcome this. The next major component is sleep apnea. Sleep apnea is a major public health problem. Prevalence of sleep apnea in obese individuals with diabetes is as high as 86%. People with sleep apnea shows increased insulin resistance, increased risk of development of diabetes. Whereas in people with diabetes and sleep apnea, they have poorly controlled diabetes and increased risk of cardiovascular events. So OSA is considered as a comorbidity of type 2 diabetes, and it is more prevalent in people with diabetes compared to those without. OSA causes sleep fragmentation, leading to excessive daytime sleepiness, leading to reduced vigilance. Excessive daytime sleepiness can be assessed by a Perth sleepiness scale, or there are other validated questionnaires also. But the severity of OSA alone is not a predictor of the risk of a motor vehicle accident. In addition to the severity of OSA, associated comorbidities, medication, sleep-wake schedule, sleep deprivation, degree of subjective or objective sleepiness, and history of previous motor vehicle accident, all these have to be considered while assessing for fitness for driving. The risk of motor vehicle accident is 2 to 7 times higher in people with sleep apnea. For those with severe sleep disordered breathing, the risk is higher. And insufficient sleep, usually less than 5 hours before driving, increase the risk of motor vehicle accident. Increased daytime sleepiness can be due to other causes in addition to obstructive sleep apnea, like poor sleep hygiene, periodic limb movement disorder, circadian rhythm disturbance, etc. Treating OSA with nasal continuous positive airway pressure reduces the risk of daytime sleepiness and the risk of motor vehicle accident. So those with OSA treated successfully, or those untreated with hypoapnea index less than 20 events per hour without any daytime sleepiness are considered eligible to possess driving license. The next comorbidity is obesity. Obese individuals are at risk of developing hypertension, diabetes, dyslipidemia, and sleep apnea, various atherosclerotic vascular complications. And driving itself is a sedentary activity, and those with obesity are at increased risk of osteoarthritis, which can cause pain while moving the leg. Hypertension need to be controlled before resuming driving, and those who are having very high blood pressure or malignant hypertension or blood pressure more than 180/110, they should not drive till the blood pressure is under control, because uncontrolled hypertension, they are at increased risk of acute myocardial infarction, stroke, heart failure, etc., which can interfere with driving. And sometimes antihypertensive medication can also cause dizziness and tiredness, which can interfere with driving. Hearing impairment. Auditory pathway is metabolically highly active. In people with diabetes, microangiopathy, neuropathy, oxidative stress, all results in impairment of auditory function. In addition to that, associated comorbidities like dyslipidemia, hypertension, obesity, smoking, and alcohol consumption add to hearing impairment. The prevalence of hearing impairment is higher in people with diabetes compared to those without. Hearing provides important information during driving, like providing information about the approaching vehicles, hazards, potential vehicle problems. Even though hearing impairment can affect driving theoretically, it does not affect the crash risk or the ability to drive vehicles safely. People with hearing impairment are usually more visually observant, drive more cautiously, and use mirrors more to compensate dioxide for the hearing impairment. But some countries there is restriction for those who are having hearing loss of more than 40 decibel. They are considered not fit to hold commercial driving license. Various medications also. Recent change in the treatment of diabetes or addition of insulin or those drugs with the high risk for causing hypoglycemia. So, in such patient, it is better to refrain from driving till the blood sugar values are stabilized with the new treatment. And frequent monitoring of blood sugar also helps to avoid hypoglycemic episodes. In addition to that, sedative medications like medication used to treat diabetic neuropathy can also interfere with driving skills. But these effects are maximum during the initial days, and subsequently people develop tolerance. Various substance abuse like alcohol and other substances which have got additive potential can also impair with driving skills, as alcohol can cause either hyperglycemia, or it can prolong the reaction time, impair the coordination, impair the judgment, etc. So medical evaluation of a person for driving fitness include assessment of history of hypoglycemia, assessment of diabetes-related complications, especially visual problems, neuropathy, and vascular complications and sleep apnea. So history of diabetes like duration, level of control, recent change in medication, history of hypoglycemic episodes, its severity, episodes requiring second person or medical support, etc., and hypoglycemic unawareness, diabetes-related complications, comorbidities, knowledge regarding the self-management skill, knowledge about diabetes, warning symptoms of hypoglycemia, and self-monitoring of blood glucose and self-management skills are also important. Drug history regarding the drugs which can cause hypoglycemia and sedative drugs, etc., and the history of substance abuse. So with this background, we propose a scoring system to identify drivers with diabetes at a risk of motor vehicle accident, and the score varies from 0 to 38. So the scoring system contains treatment-related questions, driving-related questions, hypoglycemia-related questions, and self-management-related questions and complication-related questions. So the treatment-related questions are you on insulin or secretagogues, and which carries, if yes, 3 points, and are you on intensive therapy or tight glycemic control with insulin or secretagogues, it carries 4 marks, and the maximum score in this section has to be taken. Driving-related questions, are you usually going for long distance or long duration drive, which carries 1 point. And hypoglycemia-related questions like any history of mild hypoglycemia in the last 6 months, history of moderate or severe hypoglycemia in the last 6 months carries 8 points. Any history of recurrent episodes of moderate or severe hypoglycemia in the last 6 months, and any history of hypoglycemia unawareness which carries 14 points, and any history of hypoglycemia-related driving mishaps in the last 2 years. The maximum score in this section is considered. And self-management skill questions include, if there is no knowledge about the self-management of hypoglycemia, it carries 2 points. And complications for comorbidities-related questions, do you have a visual problem interfering with the driving skills, carries 6 points. Sleep apnea, which interfere with the driving, 6 points. Sensory or motor problems in the lower limb, 1 point. Have any cardiac or cerebrovascular problem interfering with the driving, 2 points. And uncontrolled hypertension, 2 points. And the total score is 38. So its score can vary from 0 to 38, and as the score increases, the risk of motor vehicle accident risk also increases. And the score above 6 increases the risk significantly. So advice for the people with diabetes about driving, they should possess enough knowledge about diabetes, role of diet, warning symptoms of hypoglycemia, and self-management skills. And they should be advised to not to drive if there is symptoms of hypoglycemia or blood sugar is less than 5, and check blood sugar every 2 hours in case of long distance driving. And while driving, they should always carry rapidly absorbing carbohydrate to eat if they develop hypoglycemic symptoms, or if blood sugar values are less than 5. And they should not resume driving for 30 to 45 minutes after correction of hypoglycemia. They should try to take food and medication in time. So, role of driving licensing authority. The licensing authority should be aware of the impact of diabetes on driving and take appropriate medical opinion whenever it is required. And it is driving, the licensing authorities should ensure that the people with diabetes are aware of early warning symptoms of hypoglycemia and possess adequate self-management skills. So with this background, we coined a term Rule 515/15/45/120 of driving for people with diabetes, which emphasizes the important recommendation for people with diabetes that they should not drive if the blood sugar value is less than 5. They should take 15 grams of rapidly acting carbohydrate if their blood sugar value is less than 5, or if they develop symptoms of hypoglycemia. Wait for 15 minutes and recheck, and if still hypoglycemic, repeat until the hypoglycemia is corrected, and they should not restart driving until 45 minutes after restoring normal glycemia, and check blood sugar every 120 minutes during long distance driving. So in some countries there are separate guidelines for private and drivers and commercial vehicle drivers. But there is now universally accepted guideline, and the universally accepted guideline is the need of the hour. With this, the proposed guideline is in people with diabetes. For private vehicle drivers and for commercial vehicle drivers, it's different. Those who are controlled with diet and exercise, no need of compulsory medical examination for both the group. Those with diabetes treated by glucose-lowering agents other than insulin or medication with less hypoglycemic risk. Medical examination every 5 years is optional, but for commercial vehicle drivers, medical examination every 5 years is compulsory. Diabetes treated by insulin or medication with high risk of hypoglycemia, medical examination every 5 years is optional, whereas medical examination every 2 years is compulsory. And diabetes with recurrent hypoglycemic episodes, avoid driving till the blood sugar values are stabilized. But for commercial vehicle drivers, resume driving only after medical evaluation on optimization of therapy and stabilization of blood glucose. Those with the hypoglycemia unawareness, it's safe for both private vehicle drivers and for commercial vehicle drivers. They should resume driving only after medical evaluation and optimization of treatment and stabilization of blood sugar values and regaining hypoglycemic awareness. So to conclude, driving has become an inevitable component of modern life. People with diabetes face a lot of challenges while driving. Improving awareness among the healthcare professionals, people with diabetes, public and regulatory authorities help to improve road safety measures. Thank you for listening.
Hello. I'm sure you'll all agree that it's a picture-perfect presentation. He has finished well ahead of the schedule. It was a very lucid and exhaustive presentation, touching on all the aspects of driving. So I open the topic for discussion. You can ask a few questions.
So the many patients are eligible to drive during daytime. But diabetic neuropathy is there. There is a delayed pupillary response. So once the bright light falls on the eyes, then an accommodation is delayed. So those people, even though they drive comfortably during daytime, better not to travel during night. Otherwise, within the fraction of a second, some serious problem may happen.
So they can have even early cat light. It can be anything. The most important thing is that the patient should not become unconscious on the field. One condition is a patient who is diabetic, who has an old CVA and gets a seizure during driving. So I think these people should be very evaluated. Epilepsy should be well controlled, and of course, as I said, drugs also can be studied. The other thing is that a patient who is post-MI, who is prone to arrhythmias, PT, and they may also have the same problem. So I think they should be evaluated, and if they have a ventricular tachycardia or ventricular fibrillation, there should be an intracardiac fibrillation. And then only clear for them. Otherwise, both of them will collapse on the wheel and it's a hazard to result of the public.
Raveendran sir, it's a very good excellent lecture. I would also like to add the other side of the issue. Drivers are most prone for uncontrolled hyperglycemia also because of the erratic meal timings. They usually have food from the hotels and outside fast food counters. So these are the patients who usually come with very high blood sugars also. So I think that has also to be included when you are managing patients who are frequently driving.
As driving risk is concerned, hypoglycemia is more risky than hyperglycemia. Severe hyperglycemia can also impair driving skills, but it is comparatively rare compared to hypoglycemia. So even drivers prefer to take sugar items to avoid hypoglycemia. That is one fact that leads to poorly controlled diabetes.
Yeah, that leads to hyperglycemia.
As the chair pointed out, it's a very exhaustive presentation, but often, these things have to be really translated into policy. I know, as Dr. A has right now pointed out, I know any number of people working in the public transport system with very high blood sugar levels, not getting proper treatment, and say driving transport vehicles overnight with the sleep deprivation. And there is no mechanism in our states to check whether these people are diabetic, whether the diabetes state is controlled, or are they having, sometimes these people are forced to drive for say 16 hours, 18 hours like that. So we need to impress upon the policy makers, especially the transport department, that the drivers are to undergo regular medical checkups especially for diabetes and related conditions and vision. This is not being done. Probably I think Dr. Raveendran can have a very proactive role in translating this paper into say policy which is going to be beneficial to the larger public.
One point I would like to add, because everybody is telling the ground what about the drivers. I think in aviation, pilots is very important. The government of India has decided a protocol that it is 2007. I think it is 17 years ago. The RSSD policy makers are sitting here. They can contribute. It is only permitted those 2 grams of metformin. No incidents, no GLP-1, no DPP inhibitors are permitted for the air crews. A lot of people are going to the practitioners and anyone sitting here, if any air crew is coming, you don't write any other molecule because they are not allowed to fly. So RSSD policy makers can take a decision and give a suggestion to the government of India or DGC that it should be revised because it is 17 years old. A lot of new molecules are there. Since the president is sitting here, I am raising this point. A lot of requests comes from the pilots also to revise the thing and they can take up the issue. Thank you, Ajit, for that aviation driving point. And if there are no more questions, I think I will make a concluding remark, saying that he has suggested, according legally, you can start receiving driving after 45 minutes, but in my personal opinion, better not to drive in that drive on that day, because if there is an alternate or substitute available, better to give the driving wheel to the other person, because as you know, the hypoglycemia induced by all drugs can last up to 6, 12, 24 hours. So we cannot take the risk. If there is an option, better to hand over the driving to another person. Thank you very much for the patient listening, and I declare the session as closed. Thank you.
Thank you, sir.